Thanks, everyone. All right. Well, I have no disclosures. And so to start with definitions, I just wanted to talk a little bit quickly about the difference between jails and prisons. And many of you have heard me talk about this before. Next, advance. So jails basically are local. They are run by the county or town. And jails are basically where you go when you're arrested. So the majority of people in a jail are what we call pre-adjudication, meaning they haven't had their hearing, their sentencing, they haven't had a conviction. And so once somebody has a determination and they are sentenced, then it is dependent upon amount of time. So if you are sentenced to a year or less, you spend that time in a jail. If you are sentenced for more than a year, then you go to prison. And so for me, the main thing is that it's really always important to remember that first and foremost, jails house innocent people, in addition to those that have committed misdemeanors and felonies. So it has the kind of entire gamut of custody levels. Prisons, on the other hand, are systems. They are state or federal. And because they're systems, unlike jails, prisons often don't reflect the community which surrounds them. And so they often are quite rural and out of the kind of sight of communities and put in very small towns. They are run by Department of Corrections or Bureau of Prisons, and the majority of people in prison are post-sentencing, and as I already said, they have a sentence for more than a year, and kind of by default, people with a sentence more than a year are folks who have committed felonies. And for reference, down below the jail, that is King County Jail downtown building, and the prison is Monroe's Correctional Complex that you can see is a very large facility with multiple buildings. Next slide. The other thing important to understand about corrections is kind of the flow over time. So prisons on any given day have about twice as many folks than are in jail. So in the United States, as most of you know, unfortunately, we are number one as far as the number of people incarcerated, both by sheer numbers as well as by percentage of population. And so we have about 1.6 million people in prison, as well as about 0.8 million people in jail on a given day. Next slide. But over time, because the average length of stay in a jail is actually a week or less, I should say median length of stay, the throughput in a jail is many, many more times that of a prison. So in a given year, only about 0.5 million people enter prison and about 0.5 million people leave. But as you can see, 9.5 million people cycle through jail in any given year. Next slide. A couple more definitions, because I think this is important to understand as you're seeing patients to get a sense of where they are in the continuum of corrections. So probation is basically a conditional release instead of incarceration. So where you're arrested and rather than being sent to a correctional facility, they allow you to remain in the community on some sort of supervision. Parole, on the other hand, is after you have already served a sentence, you similarly have community supervision. And in Washington, rather than calling it parole and parole officers, we call it community custody and community custody officers. So you'll often hear patients refer to their community custody officer. Lastly, we have work release, and work release is kind of a partial incarceration. So when they come to clinic, they are not in cuffs or chains, they're wearing regular street clothes, but they still are technically incarcerated. And with any slip up, unfortunately, that could very easily just send them back to prison for the rest of their sentence. Work release is considered kind of an opportunity in the last 6 months of incarceration to allow folks to work in the community, earn a regular wage, and ideally be able to keep that job post-incarceration so that they have some money under their belt and they're able to stay on their feet after release. And for reference, that picture is Bishop Lewis work release. If you have never seen it, it's actually on 8th and Cherry, only about 3 blocks from Harborview. But again, often these things are not well advertised, so you may not have ever realized that. Next slide. And then to just give you a sense, because I think this is important for those of you who know me, you know that it often is irksome when every patient who is seen incarcerated in our system often is thought to be from King County Jail. So it is true we have a direct contract with King County Jail to be their hospital of resort. So they send all of their patients to us, but patients actually come to Harborview and UW from all sorts of correctional facilities, including prisons, even though there's no prisons in King County. So in our state, we have about 37 county jails, and King County has 2 parts to it. It has the downtown facility, but then it also has Malang Regional Justice Center in Kent. There are 19 city jails, of which 5 of them are in King County, 7 tribal jails, 26 juvenile detention centers, of which 2 are in King County. And the picture there is actually a picture inside of SCORE, which is one of the newer jails, and so it's very shiny and clean. But it is a conglomeration of all of the cities in South King County got together and decided to chip in for a mutual jail. Next slide. Then, as I said, there are no prisons in King County, but there are actually 3 work releases. I mentioned Bishop Lewis, but there also is Reynolds and Helen B. Radcliffe work release that are around the city. There is a federal detention center that is in SeaTac. And lastly, we do have an ICE facility in Tacoma, which is not exactly considered a prison, but in many ways that is what it is for Immigration and Customs Enforcement. And the reality is that patients from any of the above facilities can wind up at UW at Harborview, often for specialty care, particularly the SCCA, ortho, and neurosurgery. Next slide. All right, so more around HIV and transitions of care from corrections. So obviously the major benefit of transitional care is the continuity of care. Like transfers from hospital to hospital, people caught up in corrections go through multiple different systems. They move from prisons to jail to the community. They often go to hospitals around the state based on facilities they're in. And as you know, we don't have a universal medical record, and therefore a lot of their care gets lost over time, and which becomes a problem with, I think, ongoing long-term continuity. So transitional care really helps like that. It's a time when you can give education regarding medical and social services available post-release. Many patients I see, even if they had been known to be living with HIV prior to incarceration, frequently have never accessed the system and have no idea of the resources that potentially were available to them. It decreased costs of duplication frequently, and I see this a lot. Folks get out of corrections where they've had a lot of their immunizations, they've had a lot of labs, and they get out of the facility, and all of that work is kind of restarted and done over again. And lastly, and I think probably somewhat very importantly, it provides emotional and social support to folks getting out of a correctional facility. It is a really, really tumultuous time in their lives. It's very anxiety provoking. There is a huge fear of being reincarcerated, but in addition, it is a time of extreme isolation, particularly folks who have been in prison for long periods of time. The entire world has changed around them without them there. And frequently in their minds, they are imagining the world before they got arrested and think that all of their friends and relatives kind of are still the same as they were pre-incarceration. And it is a very difficult world to reintegrate in, and often is very disappointing to folks when they actually get out. Next slide. So this is a very famous slide in corrections and was done in Washington State by Ingrid Binswanger. It's probably pretty obvious, but it is the first study to really look at mortality rates post-release. And what you're looking at here is the solid line is average mortality rates in corrections. The dotted straight line across the bottom is the average mortality rate in the community. And as you can see, that second bar is the mortality rate 1 to 2 weeks post-release, which skyrockets, and many of those deaths are related to overdoses, as well as suicides. And I think that's also really important to recognize. And even when you go greater than 9 weeks post-release, that mortality rate still remains above the average mortality rate in the community, probably for a multitude of reasons. Next slide. So we do a really poor job in the United States doing transitional care. And this is an example from Texas. And what's really important to know about Texas is that upon release, Texas only gives 10 days worth of medications. And as you can see on the bottom is that by day 10 after release, only 5.4% of patients releasing from their prison system filled a prescription in the community, which basically means almost 95% of folks releasing from their prison system had a gap in their antiretroviral therapy. And even by the time you get to 60 days, less than a third of people had picked up a prescription. So there is this huge loss of care and engagement upon release from a correctional facility. Next slide. This is a slide to show that during incarceration, people's numbers look much improved. So both their CD4 count and their viral load are much improved. And people think and often misunderstand that it is not because we deliver every dose of medication to our patients. It's that when you incarcerate folks, you take away their freedom, you put them in a cell, and they live a very structured lifestyle. Suddenly taking medications becomes much easier. You've taken away a lot of the normal life stressors that people have to deal with, including figuring out where to live, what to eat for your next meal, and to a large degree, removes substances from people's lives, although I don't think removes them completely, and certainly does not remove the thought of substances. But going into more detail here, as you can see, blue is during incarceration, and on the left-hand side of this chart, you're looking at viral load, and viral load went down 1.2 0.8 log during incarceration, and in the green, you can see post-incarceration, the viral load goes back up. Similarly, on the right-hand side of the chart, you're looking at CD4 cell count, and during incarceration goes up, and after incarceration, it goes down. Next slide. So I kind of think of release as a pyramid that has been flipped over, meaning that, as I said, during incarceration, due to life circumstances, people's health care become the focus of their lives because that's often the only thing they have and the only thing to think about, to the point where sometimes folks get somewhat really, really obsessed about their medications and adherence and tracking their numbers, where when you get out and people get back into the real world, lots and lots of other things become the priority, including housing, employment, getting on disability, social support, which often includes reintegration with family and regaining parental rights. And then whether it's because of their own desires or whether it's because it's court ordered, they often have to do addiction and mental health services. They have to figure out transportation, get identification, and deal with all of the community custody expectations for the majority of folks. And healthcare really sinks to the bottom. And what we have learned after multiple studies is that unless you help folks take care of all of these other things, they will never have the ability to focus on their health care, because all of these other things become a pressing priority in their lives. And it's not because they don't want to take their meds. It's just that all of these other stressors and priorities, which, as you can imagine, impact whether or not they go back to prison, become the focus. And so I think there tends to be a lot of blame and a lot of judgment on folks. But the reality is, and I can speak for myself, I know I'm terrible at taking medications, and I don't even have all of these stressors in my life. Next slide. So what does a release plan actually look like? So one is, you need to make sure that folks discharge with an adequate supply of medications, which actually is easier sometimes than it sounds. In Washington, we tend to release people with a 30-day supply of their medications, which is a lot compared to other states. In addition, they also release with whatever they had left in their ongoing prescription that they had on person. The majority of folks that I see in prison do have their medications on person, as opposed to be delivered a dose of medication on a daily basis. In jail, it's a little bit trickier because you have no idea when people are leaving. And so one tactic, if somebody is on a stable regimen, is sometimes we ask that the providers, and for King County Jail, it's now often Dr. Liss, is telling them to put a week's worth of medications in the patient's property, because getting back your property is a pretty standard process in a jail. And so if we put a week of medication in their property, they are almost certain to get it, as opposed to having them come to medical on their way out the door, which is almost never done and often forgotten. It's also obviously important for adequate insurance coverage, and we in Washington are fairly lucky in that one. We're an expanded Medicaid state. And early on, the Washington State DOC negotiated with a healthcare authority. So to understand, rules changed about, I don't know, maybe 5 years ago, where if you go to jail and you're there for less than a year, Medicaid is suspended rather than terminated. So when they get out of jail, often there is a lot of confusion because people think that they don't have insurance, and they actually do. It's just often in suspension status, and the patient or the clinic needs to notify the healthcare authority that the person is now out of jail so that they can unsuspend their Medicaid, which saves them from having to reapply and do another application. However, when you go to prison, because it's more than a year, usually insurance is completely terminated and requires someone to reapply. However, due to the negotiations that DOC had with healthcare authority, is we made an agreement that we can apply on behalf of the patients up to 90 days prior to release. It then goes into a pending state, and on the day of release, the patient or the facility ideally notifies HCA that the patient has released, which will basically turn their insurance on. Often, however, the glitch is that it takes sometimes somewhere between 24 and 72 hours for that to be uploaded into the computer system. And so when you check on the patient post-release, it looks like they don't have insurance. This has become an increasing problem, particularly in the day and age of treatment for opiate use disorder, in that for ARTs, often patients have enough to last them. But frequently for treatment for opiate disorder, they have a very limited to no supply upon release, which makes getting their insurance activated or giving them appointments soon after release more critical, and that often runs us into some problems with that computer delay. But we do a pretty good job. Next, obviously, a release plan includes linkage to community providers, and that includes a medical practitioner, as well as a case manager. And I think for case management in particular, and I think we don't in DOC, and we're going to try to hopefully over time do a better job of this, but a warm handoff to case management is really, really important because, as I'll probably mention multiple times, trust in this population is really strained and they don't trust folks. And knowing somebody and having a friendly face means all the difference in the world. And so I think from a gold standard and ideal practice is really to set up some sort of video visit, if not an in-person visit, for somebody to meet their case manager pre-release, particularly folks who are newly diagnosed or who have never been in case management previously. I think for folks who have an established case manager in the community prior to arrest, it may be somewhat less important, although it still gives an opportunity for continuity to know where the prison system is kind of leaving the patient for the community to kind of pick up. I think it's also, and I know for some of the case managers in Madison Clinic, we've had conversations about the fact that frequently when folks get out of prison, there are a lot of really, really smart and abled folks who release from a correctional facility. But regardless of how able they may seem, that first couple of weeks out of a correctional facility are really, really stressful. And regardless of how kind of able somebody seems and how much they say they got it, the reality is most of them don't have it and really do need a fair amount of support. And I highly recommend multiple visits over those first couple of weeks in the community. I think once you start getting into months post-incarceration, within that first year, you get out of that highly, highly stressful kind of 50 million things to do per day into a state of great isolation. And so, although again, they may seem like they don't need a lot of support, that isolation often is what contributes to suicides, depression, and lots of mental health issues, as well as anxiety. So I think these folks, many times, particularly folks who have spent a long amount of time in a prison setting, need way more support than they may be willing to admit to. Next, upon release, we really try to give folks dates and actual times of appointments on a written piece of paper. And that includes for places like Max Clinic and Mod Clinic, that although they're walk-in and people can go anytime, there is more of a sense that someone will show up post-release if they have a piece of paper in hand that gives them an actual date and time to give them some accountability. And then we do fax records to every clinic around the state for these follow-up appointments. If you are a provider and somebody just released and you don't have records, I would always check the media tab in Epic, as often there are scanned records in there. I know frequently people can miss their first appointment and usually wind up in the ER or admitted, and then kind of all of their records get lost because people don't realize that as part of that scheduled appointments, records were faxed and are on the media tab in Epic. And so you do actually have all the records if they were in prison, and jail records are now in Epic under the Care Everywhere. And then we try to schedule people for special services upon release, including mental health and substance use treatment. For mental health, one of the hugest barriers is the newer state laws, which I think were very well intentioned, but often people don't take corrections into account when they make these laws. And the law basically says that mental health appointments have to be in the county in which you're living based on reimbursement. The problem is, as you can imagine, if we're making an appointment for somebody post-release, they are technically not currently living in the county to which they will be releasing to. And this has led to a lot of confusion and inability to adequately schedule mental health appointments in the community, which to me makes no clinical sense. And so keep that in mind, that has been quite a barrier for us. Next slide. Then there are other things that we think about upon people's release, including transportation. Often people need help just getting from the prison to where they will be living, but then often people need help with transportation to get to appointments. They may or may not know the area to which they were released to. They don't know the bus system, and all of that becomes really scary and stressful. Although they're eligible frequently for food stamps post-release, they often are not set up to have that first meal. And so making sure that people have adequate food supplies is important. Clothing, you guys may or may not realize it, but often when I see people in clinic, I know when they're still wearing prison shoes and things like that, which to them is a sign of shame and stigma. And so getting new clothing that is different from what is state issued from the prison system often is really important to them. We did change our system of identification in prison because previously prison IDs were not considered valid. We now have a system where the individual who's incarcerated signs their prison ID so that it actually has a signature on it, which helps them with using that ID in the community. And many classification counselors pre-release also apply for somebody's social security card so that they have that in hand upon release or it's mailed to them. When necessary, we do apply for disability pre-release. Our program includes a peer support program, which I think is very important for stigma, to help with that marginalization and isolation, as well as medication adherence, and to have somebody that's kind of like a cheerleader. There are a lot of legal issues that persist after release. As I said, people are on parole or community custody and have a lot of requirements. Often, from a medical perspective, we interfere with some of those requirements without realizing it, including by giving prescriptions that may pop up on a urinalysis without explanation. Um, Particularly in times of COVID, I think more and more people are releasing with a GPS bracelet, which is pictured in the photo. Those GPS bracelets, having worked with a couple of people now who have been released, is extraordinarily stressful. And to understand that if you're on a GPS bracelet, there are different programs, some of which you are confined to your house, and even to go to the corner grocery requires permission 24 hours in advance to leaving your household. Otherwise, you are rearrested. So some of those GPS programs are ridiculously onerous. And coming to the doctor obviously requires permission as well. And then there are a lot of legal fights about parental rights and paying back fines. I know I've been involved with some of you who have had huge fines that if there's not a payment plan set up, kind of sporadically takes away their entire salary and makes it very difficult for them to make steady payments for their bills and for rent. And getting them and helping them get a payment plan is really critical to their success. Next slide. Housing first. Housing is key, and without housing, as all of you know, it is very difficult to focus on your medical care. And I just wanted to briefly go through, so as you know, our DOC release planning program does get Ryan White money for supporting folks in housing, including emergency housing, shared group or living, often historically referred to as clean and sober housing, as well as independent apartments as people transition to HOPWA and other housing programs. One of the things to understand about housing is even without the Ryan White money that is specific for people living with HIV, is that many people getting out of prison are eligible for 3 months of housing through a DOC program. So about a decade ago, DOC went to the legislature in that in our state, in order to release, if you have what our state considers a violent crime, it requires an address. And the way sentencing works in our state is you get what is called an earned release date, which is basically the earliest you can release from a prison setting. But then you also get a max release date. And the difference between the earned release date and the max release date can be a couple of weeks to more than a year. And often people were kind of languishing in prison because they had no address to release to in the community, and they would have to stay until their max sentence and then would release homeless, which I would agree is a ridiculous system. So what DOC did is they went to the legislature and they basically said it's actually cheaper for us to pay for 3 months of housing in the community than to incarcerate someone up until their maximum custody date. And so about 10 to 15 years ago, they developed what is called the ERD Housing Voucher Program, so that many of our clients, even if they weren't living with HIV, are eligible for that program, which pays mainly and only for shared group living. And so for the first 3 months post-release, their housing is supported by DOC itself, as opposed to any special funding for folks with HIV. And right now, our DOC housing case manager upon release is Patricia, if you have not already met her. And in that photo is a picture of the new building called Project 1426 by Weld Seattle, which is the first building in partnership with Weld, who is very supportive of people who have been incarcerated and will be solely for folks getting out of prison, and is downtown. Okay, next slide. So medications for opiate use disorder are we are increasingly trying to get people started on these medications pre-release. Relapse is one of the primary reasons that folks kind of drop out of medical engagement upon release. And we know that medications for opiate use disorder not only improve HIV clinical endpoints, but also reduces recidivism, particularly since we criminalize drug use. And so people can start, although I have to say that the progress in this program has been really, really slowed down by COVID, can start on opiate use disorder medications, specifically naltrexone or Suboxone, up to, I think it's 30 days pre-release, so that by the time they release into the community, they are up to full dose. I think we do need to be careful, and I have seen mistakes on this from a provider perspective, is to understand, one, is that to start people on Suboxone or methadone, people do not need to relapse first, that they can be started immediately upon release. And that is approved by all of the federal guidelines, including methadone. However, to understand that most of these folks, if they have not yet relapsed, do not have any tolerance. And so it's really important. I normally start people on only 2 milligrams of Suboxone with the idea of maybe going up to 4 within those first couple of days. But even on 2 milligrams, a lot of people complain to me that it's too strong. And so dosing becomes really critical, which is why it's much better to start pre-release so that folks don't have to go through that dose escalation in the community, which often can be a trigger. Next slide. There are lots of barriers, though, to release planning. Dates and times of release are often unknown for a multitude of reasons. There's a lot of anxiety about going out into the community that we talked about and starting over. And getting out of prison is a thing to celebrate, and that partially is what can lead to overdoses as well as rearrest. And distrust is huge. And I think to understand that medical systems have been extremely stigmatizing, and our bureaucracies that do not treat people who have previously been incarcerated well. And gaining that trust is really, really important. One of those things, the way I wrote it, actually, now that I'm looking at it, sounds weird. Duty to report. What I meant to say by that is that one of the first things I tell people when they're in the community is that my role is not to report them to law enforcement if they have broken their community custody or have done something, quote, wrong. I think that's actually a really, really important thing to verbalize to patients, because they will assume that if they come to you and they have a warrant, that they're going to be arrested. And so that's why people don't come to medical care anymore when they have a warrant, because we are part of a system. And so whether you think it or not, it's really important to let people know that that's not the system you're a part of. And to, as I said, have a lot of visits initially to gain that trust and rapport with the patient in order to improve that engagement. And even folks that I know really well from prison, when they get out, I still often will see them weekly for a couple of weeks until they're kind of stable and on their feet. Next slide. And so this is my last slide, and I know we're at time. I just wanted to also give a plug for the system we have set up to improve coordination of care, specifically from King County Jail. And so, as many of you know, Dr. Hillary Liss on a weekly basis now sees folks by telemedicine while they're in jail, which has really helped improve engagement and establish that rapport with the clinic. But we also have a weekly telephone call, which you may or may not know about, which includes Dr. Liss, it includes the release planners from King County Jail. It includes King County Public Health. It includes one of the social workers from Max Clinic. It often includes myself, but certainly includes the social worker from Department of Corrections. It includes all of the different programs from Bailey Boucher. And we talk through for an hour all of the folks that are currently in jail to help establish their release plan through coordination of all of the different agencies, which sounds really simple, but the reality is groundbreaking in that most facilities never coordinate among agencies like that, and it has been a huge success. And on that note, I think the last slide is the end. And I will stop there. I know I'm at time. I don't know if there's time for questions, Sharisha.
Thank you, Lara. That was an excellent overview. And we can open it up for questions. We do have some time for questions.
Thank you, Dr. Strick. We do have a question in the Q&A box about the difference between the word parole and community custody. Why use community custody as opposed to parole?
Good question. So the answer is there absolutely is no difference. My understanding was the change occurred about 10 years ago with the kind of, I think it has more to do with political correctness than anything else. I think Department of Corrections wanted to feel, that we are not always trying to be a punisher, but to support people in the community. And so they changed the wording to be more one with the community. Other than that, there really is no difference. And I will state just, no problem. I will state just like there are good, there's good doctors and bad doctors, there's good nurses and bad nurses, and there's, great doctors and great nurses. The same is true in community corrections, right? Some of them really, really do take on a kind of supportive, kind of rehabilitative role for their clients, as opposed to others that really do kind of assume much more of a punitive role. And so it really, really varies, and sometimes they can be your best ally in supporting folks in the community.
Thank you. Another question, do you see any difference between women's and men's prisons?
Yes, there is a huge amount of gender bias. And in that, I think what I mean is from a community perspective, there is a tendency to see women as victims and men as perpetrators. And I think the reality is it goes both ways. And so as a result of that bias, there tends to be many, many more programs and options in women's prisons because of community engagement and support and wanting to give back to female facilities. And I think among the officers, there definitely is more lax rules at the female prisons than there are at the male prisons. So I think that is probably one of the biggest differences. Then on a more concrete level, women have children and give birth. And so there also are more parental rights given to women than there are to men, even though my experience has been is that they are just as important and meaningful to fathers. But the women's facility has the baby unit. It was the first in the country where women who don't have any open CPS cases or other reasons that there would be a contraindication, and they have and I always forget if it's a 2 or 3 year sentence or less, and they give birth while incarcerated, they can keep their child in prison with them in our baby unit. But since the child is technically not incarcerated, they maintain their community insurance, and their WIC and supplies are actually mailed in, and they go out to the community to see a pediatrician. So that is obviously another difference.
Thank you. Question about the IF project. There's a program at the women's prison,
Yep.
the IF project, that provides support prior to release and after release. Is there any hope for another program for the for men who are incarcerated?
Yeah, so there's a lot of these one-off programs all around the state. I think the IF project has gained a lot of press, and actually, I showed you a picture of that WELD project with the housing that will be for people post-release, and they, of course, partnered with the IF project. And I think what's amazing about the IF project, right, is that it was started and the idea came from a police officer. There are lots of different programs around the state. None of them are identical to the IF project, but they all have their benefits. There are both education programs, there is the Fair Start program. There are lots and lots of different programs, some of which may only be at one facility, some are at multiple facilities. I think what's really, really important to understand is that although each one of these programs has merit and is awesome and has benefits, no program could be scaled up to the number of people we incarcerate. And so part of the problem of our system is that we have so many people that are incarcerated that it is absolutely impossible to scale anything up to meet the needs of everyone who is in a facility. And so there are handfuls of people that get great services, whether they're in a female or a male facility. It's just that not everyone gets them.
Okay, looks like that's it for the questions.
Thank you all for participating this morning.
And thank you, and sorry for the technical difficulty.
That's okay. This is the Zoom era now, so thank you for your patience. Have a great day, everyone.